let's open this back up for question and answer for all the presentations in the morning. I don't think we got enough in. I think there's probably some more questions and answers that can happen. So start off with a question.
I'd just like to say that for those of you who don't have access to the chat, there is just lots of love in here for our PATHS team and for the folks doing this hard work on the daily. So just wanted to point that out in case you can't see all the love.
I do have a question. Are there any like representatives or like PATHS organizations on this meeting right now that have not been trained in PATHS? We do offer continuing education credits as well.
I have a question, guys. Any plans to make it a national model? I speak to folks from states ranging from Alaska to the Dakotas, and folks that were at INSHU have been very curious with follow-up from some of that data, and they're all kind of wondering, well, how do we implement peer navigators in our clinics? Because you guys are definitely leading your fingers on the pulse, and you're very innovative. And so I've spoken to folks from across the country that are all asking me, because I'm situated in our neck of the woods, they're like, how do we bring it to our states? I'm like, well, we have some peer experts in our state, and hopefully they'll be educating folks beyond the state lines. I'm not the right one to ask. So just wanted to see if there's any plans on being able to kind of maximize the knowledge of what the incredible work that you guys are doing to folks outside of Oregon.
Yeah, that's something we need to probably increase. We're hoping to partner with INSU to develop like a toolkit for implementation, which would be broadly disseminated. There is a few things that are unique about Oregon that make this work. So obviously one is we have broad access to Medicaid, and the other is that we've got an established network of compensated peers. So fortunately, there's no reason why other states can't emulate that. It's just sort of a matter of political will. So important priority for us. And I think it's kind of foolhardy to try to do it without a sort of compensated network of peers. So that'll be like a big lift for other states, I think. But yeah, maybe we can get some CDC funding. I agree with that sentiment, definitely.
So Jude has her hand up, and I know she's going to respond to this and has the best answer for all of us. And really, it's having funding from behavioral health and like-minded folks. So, but Jude, please.
I mean, I think that the question is the PATHS model, Anna, is something that we're going to package up for INSU. But I think it should really be noted that the infrastructure for this and the frame is being funded by SAMHSA. So SAMHSA is paying for the peers, and we have Measure 110 peers. We have other peer teams. There are peers that are funded and reimbursed through Medicaid. There's a whole waiver component discussion that we've had, I believe, 5 or 6 times about getting harm reduction peers covered by Medicaid through the waiver. But what it was, Anna, is CMS wanted data. So we've spent the last, 3-4 years getting the data that harm reduction peers actually do improve health outcomes, including decreased substance use, decreased hospitalization, et cetera, et cetera. That's a whole nother presentation. But I think when you think about it, the directions of how to get this done, it has to come from not just, and I'm not dissing on CDC, but when you think about public health is population-based, and SAMHSA is looking at implementation and individual level. CDC will fund developments of models. SAMHSA is funding the implementation of those models. So you have to kind of think about it. So I think as we look to disseminating, kind of bringing it out with what do you have, what is funded in your area, where can you integrate this, and then how do you add funding? So again, you're not supplanting the peers from the important work that they do that's also about overdose prevention and recovery supports, harm reduction centered recovery supports, et cetera, et cetera. So it would be great. And I know that there's a lot when we think about overdose and overdose prevention and response that relates to peers on the ground, handing naloxone to people who can use it on themselves and people that can use it on the people sitting next to them.
And I would respond as well that we need everyone's help on federal appropriations. So when it comes to SAMHSA and CDC, the funding at the national level is pitiful. And just a few years ago, SAMHSA wasn't even allowed to spend any money on hepatitis C until we got the hepatitis into the appropriations language. So, really, everyone needs to be involved at the national level on speaking out about why hepatitis needs to be funded. The Center for Disease Control has $40 million for all hepatitises for the entire program. That's less than 2% of the budget of the division of the CDC division that houses HIV, STD, TB, and hepatitis. So we have 5 times the problem, but we have 2% of the funding. So that's where we really need help at the federal level of everyone to speak to their representatives and make sure that they know how important it is that this gets funded. You know, we have a national plan proposed by the White House, but we have no appetite by Congress to take it up. And again, people speaking to Congress and telling them we need a plan, we need a funded plan. And the White House wants $12 billion out of this Congress, which, you know, for those of you who follow Congress right now, it's kind of, you know, not realistic, but on the other hand, it will save $20 billion in 10 years. So, you know, we've got an opportunity here. They care, and we just got to make sure it moves through. And hopefully we'll be seeing a bill soon that everybody can respond to. If we don't push on a national level, Oregon's never going to get the funding either. So it kind of takes both. And I would respond as well that we need everyone's help on federal appropriations. So when it comes to SAMHSA and CDC, you know, the funding at the national level is pitiful. And I mean, just a few years ago, SAMHSA wasn't even allowed to spend any money on hepatitis C until we got the hepatitis into the appropriations language. So, you know, really, everyone needs to be involved at the national level on speaking out about why hepatitis needs to be funded. The Center for Disease Control has $40 million for all hepatitises for the entire program. That's less than 2% of the budget of the division of the CDC division that houses HIV, STD, TB, and hepatitis. So we have 5 times the problem, but we have 2% of the funding. So that's where we really need help at the federal level of everyone to speak to their representatives and make sure that they know how important it is that this gets funded. It's, you know, we have a national plan proposed by the White House, but we have no appetite by Congress to take it up. And again, we need people speaking to Congress and telling them we need a plan, we need a funded plan. And the White House wants $12 billion out of this Congress, which, you know, for those of you who follow Congress right now, it's kind of, you know, not realistic, but on the other hand, it will save $20 billion in 10 years. So, you know, we've got an opportunity here. They care, and we just got to make sure it moves through. And hopefully we'll be seeing a bill soon that everybody can respond to. But, you know, if we don't push on a national level, Oregon's never going to get the funding either. So it kind of takes both strategies to move this forward. We don't want to take away from HIV, but we certainly want more funding. That's what we're looking for. So, and it needs to happen on a syndemic level. What we need is the silos to break down so that everybody can work just like PATHS is working, and everyone works together across all departments of every organization and across the health departments, et cetera. So, yeah. Other thoughts, comments, questions for the folks' presentations this morning? I know we didn't get, let me make sure he's back on before I call him out. Arslan's not back on yet, so I'm not going to ask you to ask questions of him. So other thoughts, questions? I guess, you know, Joanna, do you think that, so there was legislation that was passed this year around training peers and making sure they were getting a paid wage. Do you think there's more that could be done to support you guys on a policy level, whether that's little policy or big policy, whether that's Salem or whether that's at CCOs? What can we do to help push the peer model?
I would think just, advocating for the peers and like making sure that they have like the proper equipment, like the phones, the transportation, access to providers, and additional training, and so they can like grow in their role and become, yeah, and work their way up throughout, being have goals themselves. So that's all I can think of.
So,
Really.
so does that training exist currently for peers?
The past,
Other than your paths training, but outside of that, does that exist?
not really. I know, like working at the HIV Alliance, we were always, they always had trainings for us. But also another thing, is, I feel like the weekly meetings, our weekly Friday meetings, for the Oregon Hope study was helpful. And so making sure that the peers have access to management and other providers and other people that can make decisions, and that they're all working closely hand in hand. I don't know if
Lauren,
that answers.
That's good. Anne?
sorry. Lauren, I just have to say what this conversation is reminding me of is that everybody on this meeting today is invited and welcome to come to the Oregon Viral Hepatitis Collective meetings. We have monthly meetings, and this is where all these brilliant ideas can jibe and synergize and get moving. So please consider being a part of this, part of the Oregon Viral Hepatitis Collective. We can, we'll do some brain jamming around what's the best time for people, because we really want, particularly you peers and the community health workers and folks out there on the front lines at the LPHAs and folks doing the outreach to be at those meetings. Dane's there. He's always the voice of community outreach and the frontline stuff, and we just love it, and we need more. So shameless plug, but not so shameless, because hello, look who's sponsoring the meeting.
Yeah, thank you. And again, we have gone back and forth about what is the best time for the collective to have a meeting. It used to be in the past that we had a lot of providers that were on the meeting, and the best time for them was after clinic. And so we scheduled the meeting at 5 o'clock. That may not be the best for the collective now. So if people can be more free to join at other times of the day, please feel free to let me know what would be a better time for everyone to be able to participate in the collective. So it's an hour call once a month. It's not a huge deal. We won't like take your firstborn or anything. We don't want them. We have a bunch of new messages. So
Lauren, I'm wondering if you could clarify the question around the training, just so that people know. I don't want people leaving thinking there's no peer training in Oregon. There are two major organizations. One is the MHAOO, the Mental Health and Addiction Association. There's MACBO. There are peer certification programs, and then peers that are certified have to get continuing education units. I think you might have been asking, is there specific training around paths? But maybe I misheard. I just wanted to put that out there.
Thanks, Jude. I was actually asking about all of it. I was kind of curious about what how those additional trainings that I know are available are actually working in the community. Like the fact that Joanne didn't really know they were there speaks volumes to me. They need to do more outreach to get more people trained and get more people educated about what they offer. But I don't want to put that on them. We all have to work at that together. It always, it's collaborative work to get the word out there. So, but thanks, Jude. That's kind of what I wanted to know is, are these people that are getting paid by the state doing a good job and reaching you guys?
Yeah, so they're a community-based agency. I just really, this is where, like, when we talk about silos, this is a whole like silo that maybe it sounds like the infectious disease component of our state isn't aware of that exists. I just want to put that out there, just because if people want more, you can follow up with links about where to go to get trained and certified. All Prime Plus peers are certified. All the past peers so far have been certified.
I love it, Jude. Thank you so much for ensuring that we know that. And I put a link to MacBo in the chat. And I just want folks to know it is on Shannon and my radar to really engage with our burns, our mental health and addiction partners across Oregon. Burns are the behavioral health resource networks across Oregon who are supporting people living with substance use issues, mental health issues, etc. As Jude so eloquently told me when I stepped back into this role, you are not going to create new networks for viral hepatitis elimination. You are going to tap into the networks that are already there, make friends, make partners, and see who can do what. That's not exactly what she said. She was much more eloquent. That was my translation. So realistically speaking, I love all these ideas and we need to keep them flowing. So please, folks, do think about coming to the OVHC meetings. I think we're about ready for Dane, unless anybody has a last question.